Excellent. Well, welcome everyone. So good to see you all. There are a lot of new faces and familiar faces. So thank you all for joining us. We really appreciate you spending our evening here. Um, we do these webinars monthly. So if there is ever anything you want us to cover, always feel free to put them in the chat box or send me a message directly. We'd love to cover those topics. If they're specifically related to sleep, TMJ, or even practice growth in these areas. So the best way, in my opinion, to view the webinar this evening is going to be in speaker view. So in the upper right-hand corner, you can select view, and there will be a speaker option, and then you can see a nice side-by-side of Dr. Patel and the PowerPoint. Like I had mentioned earlier, your camera is off and you are muted for the webinar. There is a question and answer box. You can type in your question or you can raise your hand and we can address those questions throughout the webinar. Our focus today, our webinar topic is from job pain to sweet dreams, so managing TMJ and sleep apnea, and of course with Dr. Mayoor Patel. You will be receiving a promo code at the end of the webinar, so make sure to stick around to get that. I know there are quite a few new faces on here. So those of you who are not familiar with True Function, we're a specialized laboratory based in San Diego. We focus exclusively on sleep apnea and TMJ appliances. This year, we're proud to celebrate our 26th anniversary. So we take great pride in employing some of the most skilled technicians in the industry, ensuring that we deliver the highest quality appliances at every delivery. So should we identify any concerns that would impact the quality of your delivery, we prioritize transparent communication. With our 7 business day turnaround, our goal is to support you in treatment and your patients as effectively as possible. So we're grateful to have you join us today. And of course, we very much appreciate your commitment to expanding your knowledge on sleep and TMJ. So I would love to introduce our favorite person here, and I know I say that every month, but I truly mean it. Our clinical director and dear friend, Dr. Mayoor Patel. So Dr. Patel received his dental degree from the University of Tennessee in 1994. After graduation, he completed a 1-year residency in advanced education in general dentistry. In 2011, he completed a master's in science from Tufts University in the area of craniofacial pain and dental sleep medicine. Dr. Patel has earned a fellowship in the American Academy of Orofacial Pain, American Academy of Craniofacial Pain, the International College of Craniomandibular Orthopedics, and the Academy of General Dentistry, and the Pierre Fauchard Academy. He has also earned his diplomate in the American Board of Dental Sleep Medicine, the American Board of Orofacial Pain, the American Board of Craniofacial Pain, and the American Board of Craniofacial Dental Sleep Medicine. Presently, Dr. Patel is the co-founder of the British Academy of Dental Sleep Medicine and the BenPat Institute. He also serves on the American Academy of Craniofacial Pain as secretary, the board member of the British Society of Dental Sleep Medicine, and a board member and examining chair for the American Board of Craniofacial Pain and Craniofacial Dental Sleep Medicine. In the past, he served as the founding board member of the Georgia Association of Sleep Professionals. Since 2003, Dr. Patel has limited his practice to the treatment of TMJ disorders, headaches, orofacial pain, and sleep apnea. Additional contributions have been published: a textbook for dental sleep medicine and numerous textbook chapters for orofacial pain and dental sleep medicine. Consumer books, one on the treatment options for sleep apnea and the other on understanding temporomandibular disorders, and various professional and consumer articles. Dr. Patel speaks nationally and internationally on topics of dental sleep medicine, orofacial pain, and TMJ disorders. So thank you, of course, for joining us, Dr. Patel. I will turn it over to you now to get started from the webinar.
Thank you, Tricia. Appreciate it. I will definitely send you a short version. Promise.
Perfect. I would love a short version.
Half the webinar right there.
But you know what? We're so thankful for all of your knowledge and you sharing it with all of us. So
no, thank you. So thank you everybody for being here this evening. This is gonna be a nice topic because this is something that comes up all the time, and you may have heard this from various people out there. For example, Anju Ely, in her beautiful cover that she did for dental sleep practice, talking about the reason why she got into, of course, sleep. But when you go into sleep, you start picking up patients with pain. And the pain I want to make reference to will be more along the lines of a temporomandibular joint disorder of some sort. I'm not going to labor those key ideas, but I want to kind of tie the two together tonight. I have about a good 45 minutes. I think I should be able to wrap this up You will have these PowerPoints. If you want copies of these slides, I'm happy to share them. Because there's a lot of key numbers and facts that you're going to see. And all of this is, of course, scientifically based. So it's not my opinion. I'll give you some of my anecdotal thing as far as a clinical experience standpoint, but I want you to look at what the literature says. And this might open your eyes to why we may need to understand both sides when it comes to treating patients. If you're in the pain camp, you got to appreciate sleep. If you're in the sleep camp, you definitely have to appreciate pain because there's so much crossover and interrelationship between the two. But before I go down that little rabbit hole, let's just go back in time. Back in the late 1990s, early 1990s, the ADA had published some opinion statements suggesting that as dentists, we need to have some form of screening in our documentation. And there's many cases I can give you where this is very important, especially when cases go to trial. They may subpoena dental records and see if there's any notations made whether a person had any pre-existing conditions. But independent of why we need to do it, we need to do it in the merit of trying to not only identify these patients, but if we find these patients, then at least address their concerns before we do restorative work. But sometimes when you do restorative work and you don't understand an underlying sleep related, or in this case, even a pain related issue, things may get worse and things may not turn out the way they do. Gold standard, of course, when it comes to diagnosing any TMD conditions based on history. All right, a clinical history is very, very important, followed by a thorough, comprehensive examination. And then, of course, when appropriate, some form of imaging to concur with it. If you come from the Academy of General Dentistry camp, in their opinion statements published in the late 80s, they say learn how to screen. None of these associations say you need to treat them, at least be able to identify them. And if you have the confidence to treat them, then please do so. If we fast forward to roughly, I think it was in 2017-ish, the ADA had published a paper talking about the role of dentistry when it comes to sleep breathing disorders. All right. And they make an opinion here saying that it's encouraged that as general practitioners, we should be screening for some form of sleep-related breathing disorder. All right. As part, once again, of your comprehensive dental and medical history intake. So you can see that screening is very critical. And why critical? Because as you're going to see as we go down this little journey here, there's a reason we should be able to identify these patients because these patients are in our practice. If you turn a blind eye to it, you're never going to see it. But now that you understand this, every day you're going to find patients that have some form of sleep and or pain or a combination of these entities within your practice setting. So just to kind of sum up, what is TMD? All right, even though the general consumer uses the phrase TMJ, it basically encompasses a group of anything from a musculoskeletal or a neuromuscular condition that can involve the joints, the mastoid muscles of mastication, along with any of the associated structures, whether it be head and neck. All right, so it's a comprehensive umbrella term. And then within that umbrella term, there's subcategories that one can identify and diagnose these patients. But if we just break down the epidemiology associated with both sleep-related breathing disorders, and on this side here we have TMD, just see what the distribution looks like. So when the sleep disorder breathing disorders, you'll see there's more prevalent in males than females, whereas with TMD, it's more prevalent in females than males. If we look at numbers, and we look at numbers from the studies that have been published, you'll see that in the age group of 30 to 60, obese not a factor. 22% of men are more than likely to have some form of sleep disorder breathing, and 17% are females. However, if we task the question, are you fatigued? Then you only pick up 4% of men and 2% of females using that data set. When we cross over to TMD, on average, and depends on whose work you read, it's basically about 6 to 12% of the general population have some form of clinical symptoms of a TMD disorder. And of course, when you look at age distributions, primarily in the middle age when it comes to sleep breathing disorders, when it comes to TMD, you're looking at the peak occurrence between the ages of 20 and 40 years of age. Now, if we take this further and we just take the sleep breathing disorder components and we cross it over with sleep bruxism and see what's the overlay look like. In sleep bruxism, it's not gender specific. It's almost equal males to females. But from an age group standpoint, it's kind of interesting. Under the age of 11, the prevalence is roughly about 40%. And the general population is actually 8%. But that number also can vary as high as 36%, just once again, whose work you read and how is this data presented. The 8% is typically a number that's used when you're taking some form of examination or board exam. And if there's question, what's the incidence of prevalence of sleep bruxism? Typically 8% is the answer you're looking for. But do you understand? There's also a 99 variability, and there's a lot of other confounding variables where these numbers can be skewed one way or the other. So what are the signs and symptoms of basically sleep disorder breathing? Well, we go all the way from subjective things like snoring, excessive daytime sleepiness, unrefreshed sleep, choking, gasping, fatigue, lethargy, depression, morning headaches. And if we go on the other side, we look at TMD specifically, we got pain in the jaw, pain in the neck, shoulders, of course, headaches, muscle soreness, limited mouth opening, ear pain, pressure, fullness, tinnitus, painful click, popping. You kind of see how the list kind of correlates, right? But there's one common thread here between these two entities, and that's this one right here, headaches. So if anything moving forward, I want you to just home into headaches, and we'll look at headaches from a different perspective to try and see what this crossover may look like. So if you look at etiology, specifically associated with a TMD disorder, typically the one that's probably the biggest culprit is parafunction. There can be other variables, but just for simplicity's sake, for me to make this point, well, let's just stick with parafunction for a minute, all right? And if we look at some of the work on parafunction, this in particular is an interesting statement published by Gales Levy and Barry Cecil, the two big iconic pillars when it comes to the space. I want you to read this and I want you to interpret this a little bit differently. So they say that in the apneic patient, it is believed that the consequent co-activation of jaw opening, jaw clenching muscles, as seen with bruxism, helps to prevent pharyngeal collapse, which therefore means that if you find patients that have a high suspicion of probably bruxism, you want to basically ask for a sleep history along with possibly testing these patients to see whether an apneic component may be present. The way you can reverse read the statement is if there's bruxism on the table, one of the things you may want to look towards is possibly apnea, right? Now, I want you to make this clear. Bruxism does not cause apnea, and not all apneics brux. I want you to hone that point because you're going to see some numbers when I bring the papers up to kind of prove that to you. So some of the most common sleep disorder breathing variables that put patients at risk is craniofacial abnormalities and of course upper airway anatomy issues. But the craniofacial abnormalities can also cross over in some instances and be a confounding variable when it comes to people with a TMD disorder. So there may be a little bit of crossover when it comes to the craniofacial abnormalities associated with both pain and sleep. Now, I told you about headaches, and I want you to understand this statement as well, that about 74% of patients with sleep apnea and 40% of patients with insomnia have headaches in the morning. So 3/4 of apneics are likely to have headaches in the morning, right? And of course, these are patients that are not treated. And about half, I mean, I'm rounding up, but about half insomnic patients, which means patients that either have a hard time initiating and or maintaining sleep, have a high incidence of potentially having headaches in the morning. So if I take headaches and we take a different class of headaches, such as no headaches, episodic migraines, episodic tension type headaches, and chronic migraines, and I take a subset of 301 individuals that are medically diagnosed with these categories of headaches, including control subjects, and we work these patients up and we see how many of them have a TMD disorder, and we cross the TMD disorder with the headache profile they have. It's interesting that in chronic migraine sufferers, 98% of these patients have some form of a TMD disorder. The second most prevalent thereafter is episodic migraines, followed by episodic tension type headaches. All right. Once again, headaches and a TMD highly prevalent in a headache population. Same set of patients, but if I then screen them for what set of these patients that had headaches have evidence of sleep bruxism, you now see that even in chronic migraine sufferers, almost 74% of chronic migraine is brux, right? So just keep that number handy for a second as well, showing that yes, high incidence of headaches in patients with chronic migraine, followed by episodic migraines, followed by medically diagnosed tension type headaches. So what then is the prevalence of a TMD disorder in patients with obstructive sleep apnea? They've been referred to a clinic to get oral appliances. So this was an amazing study done in Brazil where they had a series of patients coming into a clinic. These patients were already screened and were tested positive for apnea, but they were sent over this clinic to get worked up and get oral appliances fitted. And when these practitioners assessed these patients, it was interesting to find that 52% of these patients had symptoms of a TMD disorder, of which 75% of them were chronic pain related to an underlying TMD disorder. What we don't know is how long could they potentially have had apnea for. So that's variables off the table. But let's just go with the variable that they were tested positive, they've had apnea for a period of time, but as a result of it, these findings were pretty impressive. One in particular being that myofascial pain with and without limited opening being the most common diagnosis in this subset patient population. All right, so almost half these patients with a positive diagnosis of apnea presented with a TMD symptom. So then, if the presence of sleep disturbances in chronic pain is roughly 44%, which is about half the patients with chronic pain have some form of a sleep disturbance as compared to the general population, we will see that in obstructive sleep apnea, 72% of them have insomnia, and with patients with a restless leg, about 32% of them have some form of insomnia. So patients with TMD have a higher prevalence of sleep disorders, all right, than the general population. This was shown by Smith and his group. And what they found that in this patient population that had TMD diagnosed by the research diagnostic criteria and were tested with polysomnogram, 36% had actual insomnia, 28.4% had obstructive sleep apnea, and 17% sleep rocked using polysomnogram, not by a questionnaire or survey. So we can already see that even patients with TMD, a vast majority, about a good quarter of them, presented with obstructive sleep apnea. All right. Now, if we go further and we look at just oral facial pain, all right, it probably has an estimated prevalence of 19%. It's probably the second or the third most common pain, chronic pain. First being back, second being knee, and third being oral facial pain. So the estimated prevalence is roughly about 19%. Now, if we take oral facial pain, once again, a big term, let's break it down. How much of that is TMD? Well, the prevalence of TMD amongst the oral facial pain population is males about 2 to 8% and females anywhere between 4 to 15%. But now let's take that and break it down even further and say, okay, what's the most frequent TMD diagnosis? It's myofascial pain, right? So musculoskeletal pain is the most common TMD presentation that you're going to see. Now, if we take the pain patients and we look at some of the comorbid conditions associated with it, you'll find that emotional status being one, fatigue being the other, but most importantly, sleep disturbances also being a comorbid condition with oral facial pain. All right, so you can see how sleep is also just as critical along with all these things that we've just looked at. This is hot off the press, literally. It's not even published yet. It'll be published in June, but it's available online. It's an interesting paper that got my attention. These individuals looked at 85 patients in an outpatient clinic and basically assessed them for a TMD condition. So they came into outpatient clinic knowing that they had some form of a psychiatric component. The most common one they found was depressive disorders, which is about 75%. Anxiety was about 57%. But the interesting part, sleep-wake disorders were about 47%, of which 58.8% of them had an underlying TMD component. Now, we know anxiety, we know depression. These are variables that can be associated with a TMD disorder. But what I'm more interested in is a sleep-wake disorder, right? So there's some component of sleep-wake disorders associated with the subset patient population that presented with about 58% of them having some form of a TMD condition. Busy paper, but this just gets the nuts and bolts. They looked at female patients that had a TMD disorder. They did polysomnograms in these female patients. And they found some interesting observations. The vast majority of them were stuck in stage 1 sleep. So we know that's light, shallow sleep. They had a significant elevated respiratory arousal index. And they also had an interestingly elevated RERA index in the TMD patient population as opposed to the control. And what they found, which is interesting, is when they worked these patients up, the majority of them had myofascial pain, in TMD is associated with mild elevation in sleep fragmentation and increased frequency of RERA events. Now, think about this. Myofascial pain, which is one of the most common TMD conditions I just told you about, when you look at it from a female population set that was assessed and evaluated, they determined that sleep fragmentation, right, being number one, that you're in shallow sleep, respiratory arousal index significantly increased in this patient population, and a high RERA index showed that these patients had significant myofascial pain. Right, so I want you to just keep that in the back of your mind that some form of disruptive sleep can be contributing to some form of myogenic pain that these patients are presenting with. Another busy paper, but if we just look at the data set for a second, and try to understand what they're trying to say. So what they looked at is active trigger points. They had a series of 60 patients, worked them up, put them in a sleep lab, and said, all right, let's cross over the data and see what we find. And what they found is patients with significantly active trigger points, the vast majority of them had obstructive apnea. They also had significant hypopneas, along with an elevated respiratory disturbance index and respiratory arousals. But more importantly, they found significant oxygen saturation indexes. All right. So in other words, there was a low mean oxygen saturation, a lowest O2, and so forth. What they determined is there was a significant high number of active trigger points in participants that had severe obstructive sleep apnea. All right. So sleep apneics, in this case, they were looking at different subsets, but if you look at severe sleep apnea, a lot of them had active trigger points, all right? Suggesting that myofascial pain could be a modulating mechanism and jaw function could have interactions with nocturnal, the key here is nocturnal hypoxia, and sleep fragmentation in this chronic pain-related TMD patient population. The two things I want you to get out of here is myofascial pain being significantly seen in hypoxic patients and sleep fragmentation, no somewhat different from the previous paper, suggesting that there's a big component with some form of arousals, sleep disruptions, in this case, if we're looking at hypoxia specifically, leading to some form of myofascial pain. Is there a causal relationship between obstructive sleep apnea and TMD disorders? And this is looking at it from a bidirectional Mendelian randomized analysis. And if you look at this funnel plot, what you'll see here was an interesting observation that the funnel plot goes in the direction that obstructive sleep apnea has a causal effect on TMD, but not TMD on obstructive sleep apnea, which kind of makes sense if we think it through. Something in sleep that happens, and being that it could be hypoxia, being that sleep fragmentation, being that's apnea, or however you want to look at it, can cause or contribute to a high incidence of a TMD disorder. All right, so I want you to hold me to this as well. So if we go further and we look at population studies here, you'll see that the incidence of TMD disorders in sleep apnea is about 51%, all right, specifically untreated patients with sleep apnea. So about half these patients that we have that come into our clinic that have a diagnosis of obstructive sleep apnea almost present with some form of a TMD component. And if you go back to the Brazilian study, it's almost the same thing. 50% of them had some form of a TMD disorder. Chronic was roughly about 75%. Once again, showing some significant correlation between the two. The OPERA cohort is a big, massive undertaking. It's got some great data that came out of it. High probability of having obstructive sleep apnea was associated with an increased incidence of what we will say first onset TMD. They followed a population. When symptoms of TMD present themselves and we assessed for sleep, there was what they call a hazard ratio of them potentially having apnea was about 1.73. Similarly, if they had a chronic TMD condition, roughly there was an odds ratio of having obstructive sleep apnea about 3.6 times more likely. All right. Once again, large population study showing you that some level of component with OSA and TMD. The dilemma you and I have is these patients. They in our chair, they come in with it's for pain, they come in with it's for sleep, and we at this crossroad decision. All right, if they got sleep issues, is there possibly a TMD component that I need to take into consideration? If they come in for a TMD component, could there be possibly a sleep component associated with this? And this is where it gets kind of tricky. A lot of times we get lucky, and I think we get lucky, and you'll see my reasons for it at the end of this presentation. But a lot of times we get unlucky. And when we get unlucky, we need to really just pump the brakes and revisit this. I got a little flow chart that I'll run through towards the end to kind of show this overlapping for a minute. So where do we start? Well, I suppose where we need to start is we need to screen these patients first better, right? So when we screen them, we're looking at history of symptoms. Now, we do know that orofacial pain is reported roughly in about 66 to 84% of the patient population that brucks. So those that brucks, about good 60 to 80% of them will have some form of orofacial pain, the most common, of course, being myogenic by nature. All right, so let's keep that in the back of mind as well, because these patients coming in for pain, a lot of them may have parafunction as the driving reason that brings them into the clinic. So what are some of the causes of morning headaches that we understand? Well, clenching, right? Parafunction, poor oxygenation, there again with hypoxic events that may be associated with apnea or any other respiratory disturbances may play a big role when it comes to morning headaches. So this explains why it's not uncommon in both the sleep population and the TMD population to have headaches as a common theme. Hypoxic events, disruptive sleep, things of that sort will contribute to a headache. And on this side here, parafunction, and then maybe some sleep component can probably contribute to a headache. So you can see there's a little bit of a crossover here. The presence of an underlying sleep disorder, such as sleep disorder breathing, has often been associated with both sleep paroxysm and headaches. The key word here is associated, all right? Not to say that always it's related. There are times where people will have sleep disorder breathing, but when you do a polysomnogram on them, there's no evidence of sleep paroxysm, all right? So I want you to be mindful that it's not a one-to-one. It's maybe associated in the vast majority of these patients, as seen by the previous data, about 50% of the time. Prevalence of sleep paroxysm in adults, especially with obstructive sleep apnea, is much higher in the controls, namely 26% based on self-report, and then can range from 34 to 65 on PSG data. PSG data is probably the most accurate way of finding this. All right? On the self-reported, we always going to get underscored. But if you can put the montage on these patients and look for master muscle activity and so forth, you'll find that there's a higher incidence of sleep paroxysm in these obstructive sleep apnea patients. But once again, 34 to 65%. It's a range, right? It's not almost like 100% where we say that because you have apnea, you got to be grinding your teeth, or because you grind your teeth, I think you have apnea. It's very hard to use that bold statement. There may be a high incidence you have it, but we don't know until you get tested. Now, pain patients, including patients with TM pain of some sort, report poor quality sleep, which suggests that orofacial pain negatively influences sleep quality. Now, I want you to think about that. Pain being a disruptor affecting sleep, therefore the quality of the sleep being impacted. Some of these patients may have symptoms that may be associated along fatigue, can't sleep at night, I have insomnia, and things of that sort. But we may need to look back a little bit and see does sleep play a role here that could affect or influence the pain that they're presenting with. And we do know, unfortunately, there's a bi-directional relationship, and this has been shown over and over again. The example I'm going to use here, a poor night's sleep may be accompanied by an increase in sensitivity pain on the subsequent day. But where it gets tricky is if you had a painful day, then it's going to be followed by another poor night's sleep. All right, so we know there's unfortunately this bi-directional relationship between both these two entities, and therefore one increases the risk of the other. So pain and sleep kind of go hand in hand. So if we know that, therefore we should be making the evaluation of sleep essential when it comes to managing pain patients. Right? We cannot discount the fact that sleep does not play a role in these pain patients. We got to take this into consideration. So then if we have to look for these sleep patients, what are we looking for? Well, family history could be a good starting point. Is there a history of mom, dad, or anybody that has snoring or apnea? That could make my job easier. But also, if you look at the medical history forms, what you might find here is we know there's a high incidence of apneics if they have any of these medical conditions. So look at their health history. Even the intraoral exam, which I'll lead to in a second, could be strongly suggestive that they may have a sleep breathing disorder, right? Even though they may have come in for pain. Chronic headache sufferers feel more tired, okay? Especially females. They feel more tired. Now, this is chronic pain. But now, complaints of fatigue and tiredness or lack of energy may be as important as that of sleepiness to obstructive sleep apnea patients, especially among women, all right? So why this is important? Because you should not exclude a person's tendency to emphasize the fatigue, tiredness, or lack of energy more than sleepiness as a reason why we should not suspect that they may have a sleep breathing disorder. All right, we got to take in consideration fatigue and tiredness, okay, or lack of energy, because there's a high correlation with the two. Now, if you go back to some of these data sets that I looked at the incidence, when you look at fatigue, here's where you're going to run into it. I told you that 24% of men, 9% of females have apnea between the ages of 30 and 60. But if I put fatigue on the table where they would score high on an upwardly sleeping scale of 11 or more, you're going to find that only 4% of men and 2% of females will actually say they're fatigued. Right? So we want to be careful how we read into this for a second. But using questions like the stop or the stop bang could be more valuable. But it's got a little bit more better predictability, but you take the biasism out of just one variable, which is fatigue, right? So you got snoring, you're tired. Has anybody observed that you stop breathing? Is there a history of hypertension? If your body mass index is excessive over the age of 50, as far as male is concerned, next up front for males is 17, females is 16, of course, male gender. More yeses to this, the higher the probability of some form of a sleep breathing disorder. Well, we don't know until you get tested, but testing might be necessary. So if you look at your patients, what you're looking for is asymmetry. What am I looking for? Remember craniofacial deficiency abnormalities as a risk factor for sleep breathing disorder? Well, look for this. Look for any asymmetries. Look for a submandibular space excessiveness. Look for any chronic allergies or nasal valve collapse, as you can see that image up there. Retrognathia, which can also be a risk factor for TMD. Neck circumference, as I alluded to a second ago, and of course, body mass index. But then the other things that are clues that are rarely relevant and have a high probability of them having an issue is torides, abfractions, scalloping, retrognathia, class 2 malocclusions, possibly extracted teeth in the past. These are your premolar extraction, vaulted palates, large tonsillar tissue, and of course, Malapati scores that might be greater than 3 or greater than 4. So these are some of those clues that in your pain patients you should be looking for to identify would sleep be a probable component associated with it. So let's just dig a little deeper and look at myofascial pain for a minute. That percentage is roughly about 10.5 in a TMD population. So a TMD patient population, about 10.5% will present with myofascial pain. I want you to rewind to those two studies I told you about myofascial pain that came out of the sleep component. It is almost half those patients, right? So just remember that there's a lot of crossover here. The numbers may not align, but the incidences of having these conditions with some of these confounding variables needs to be taken into consideration. 30 to 50% of adult patients with sleep bruxism complain of headaches, either in the morning or during the day, right? So sleep bruxism patients, once again, orofacial pain, I told you that there's a high incidence of orofacial pain in sleep bruxisms, but if we subcategorize that into headache complaints, between 30 to 50% is what you're looking at. So the question on the table might be, why is this an occurrence? Why is this such a high occurrence in these patients? Well, could it be that hypercapnia could be playing a role here? And there's some interesting observational studies that were done. This right here was looking at CO2 levels. As you increase CO2 levels, there's an interesting correlation associated with the genioglossus muscle and the masseter. As CO2 concentrations got higher, the genioglossus muscle fired soon after the masseter muscle fired. There's a linear relationship to the extent of force of contraction. Higher the CO2, the stronger the contractions, right? We do know that maybe the activation that takes place as a result of this response is done so that the tongue can move forward to try and dilate the airway. So if you're having a hypercapnic situation, how do I change that? I need to move the tongue forward because the tongue is atonic at this point, especially in sleep. Well, to move the tongue forward, I got to stabilize the mandible. For me to stabilize the mandible, I got to fire up the elevator muscles. So the masseter and the temporalis fires off. Even though the observation was looking at masseter muscles, you can fire a masseter without firing a temporalis. So both will fire concurrently. So it's not uncommon, therefore, in this patient population to probably present with morning headaches as a result of hypercapnia. Hypercapnia increasing the activity of the mastoid muscles to try and move the genioglossus, and you can see there's a big cascade of responses. Do this over time. Do you not think that the muscles will start developing some form of myalgia? Do you not think that possibly this may lead to some form of myofascial trigger points and so forth, right? So I just need you to be more open-minded to the fact that there's a lot of moving variables here, a lot of crossover, which is why we do need to look at both sides of the equation. We do know the role of intermediate hypoxia and hypercapnia. In some cases, sleep fragmentation may be also the actual cause of headaches, right? So we also understand that headaches can be due to hypoxia, hypercapnia, which kind of go hand in hand. And of course, as a result of that, the brain wakes up because an arousal has to take place, leading to sleep fragmentation, and then there again, leading to the end effect of a headache that presents itself in the morning. Once again, a common symptom both in sleep apnea, a common symptom also in people with TMD, as shown in the beginning, right? So what's the treatment? What do we do for these patients? Well, I mean, quite fairly, we've got choice of sleep disorder breathing, right? We've got CPAP therapy, we've got appliance therapy, we may do surgery in some cases. We do a nerve stimulator as for the hypoglossal nerve, and maybe some behavioral changes like weight loss, not drinking at night, sleep position, things of that sort. If we go to TMD, we got medications, we got biofeedback, we got appliance therapy also, we got some form of physical medicine that can be incorporated, self-care, home instructions, maybe other things that could be used to help with TMD pain. But if you look at both these two columns, there's one common thread, appliance therapy. So here we have the opportunity of crossing over, taking care of both these two entities using appliance therapy. But if we use appliances, you also have to be mindful, therefore, depending on the type of appliance you might use, that you could make people worse. If they already have a sleep breathing disorder and you stick in a device of some sort, you may increase the apnea. You could have a situation when someone has craniofacial underdevelopment, but you're sticking in mouth guards to help with parafunctional behavior because you suspect that might be the better way to go. And now you have an apneic. All right. So we got to think this through because if we just look at some simple data here, I won't label the lower two columns, but I want you to look at the top column, the top row, excuse me. Baseline, you can see what the airway looks like when you look at the velar pharynx. If I protrude the mandible, you can see that the velar pharynx actually opens up. And if I give this patient some form of vertical, some sort of a night guard, 80% of the time I want an adverse effect, right? An adverse effect. But what I want you to get away from this is look at the middle column. If I can protrude this mandible using some method, I'm going to probably improve the area or not make it any worse than it already is. So that's the key here as far as how we're going to cross over and manage these two entities. I'll finish this off in a second, but I just want you to put this picture to mind for a minute. So how this is going to work is you're going to do your history, you're going to do your clinical exam, you're going to come to this crossroad decision. Do I not suspect this person has a sleep disorder breathing in a pain population, right? If they don't, and I don't think they do, then continue with whatever treatment you're going to provide for that patient. If the treatment results are positive, then go ahead and continue with your whatever you're going to propose to do. But if you're at that crossroad where the treatment results are not positive, in other words, I'm hitting a wall, I can't seem to improve the symptoms, maybe I'm making the symptoms worse, then you need to reconsider your diagnosis of possibly a sleep disorder breathing on the table. Because in that case, what you're going to do is you're going to go down the pathway of getting them tested, right? And then get them diagnosed. Now, if their diagnosis is positive for sleep disorder breathing, then go ahead and continue with, if there's no diagnosis, in other words, the diagnosis comes back negative, then go ahead and treat them for their orofacial pain treatment and you should be good. Okay, as long as you get the diagnosis right, knowing that airway is not a factor, then the treatment that you may align with that diagnosis, you should have positive treatment outcomes. On the other hand, if they do test positive, now you got symptoms you're going to have to manage because you're also going to have to manage the airway. This is where it gets tricky. And I'll give you some of my pointers here in a minute, but this is where clinical judgment, maybe trying it out on your patients, changing your philosophy, how you approach these patients would be important. This bottom strip here, because you now have two things you got to treat. You got the orofacial pain that they came in for, and now you got sleep breathing disorder. And I got to somehow co-manage these two entities here. All right, so we'll come back to this towards the end. I do want to make a couple points clear. This is not a cookbook, right? You got to use clinical judgment. You got to have the right diagnosis for pain. Because if you went down the pathway where treatment results were not positive, maybe they don't have a sleep breathing disorder, but maybe your diagnosis was not correct. And now you're going to blame the sleep breathing disorder. So I need you to understand that there's a lot of moving parts here. But as your proficiency improves, you'll be able to identify these patients and do what's best for them. So in this situation, if you suspect a patient with pain has a sleep breathing disorder, then you want to manage the pain. Okay, the managing pain can be prescriptions in the short run, maybe some home care instructions, things of that sort, because I need to get them educated of why they may have this pain, and then I want you to get them referred to get them tested. But you're going to have patients that are just stubborn. I got pain. I don't think I have a sleep eating disorder. I came in for pain. And you're going to have to treat these patients for pain. I mean, no fault to them. You can only educate someone so much. Then you may want to consider using devices not going to make the airway worse, right? So these are like Farrar type appliances with the jaws held forward. Because if you remember the slide I showed you, where 80% of the time some form of vertical appliance, so some sort of thickness can make the airway worse. But if I protrude them, I can actually make them better, or I don't make the airway any worse. So this is using devices like a monoblock on the picture on the bottom right, or using some form of a device that prevents a mandible from falling back, all right? But now, if you have a patient that has a sleep breathing disorder, they do go down the motion, they do get tested, and now you got to treat the pain as well as the sleep. Now you got a decision to make. And this is where you can use any type of an oral appliance, right? And if you need to modify it, and depending on your philosophy, you can add a discooning element so that you can limit the ability for them to produce a significant clench. Big parafunction's a component along with the sleep breathing component. So you kind of dual managing them. You're opening up the airway. And if parafunction is due to other reasons, not just airway, then you got this discluding element kind of built in there so they can get the posterior plates to in contact. So they don't wake up with more myogenic pain. Even though the sleep might get better, now they're waking up with morning headaches or they wake up with musculoskeletal pain and so forth. So there are ways to work this to try and incorporate both components together. I know it's a lot. I tried to compact this, just taking high points, But the key that I want you to remember is that sleep bruxism could be a common theme between airway issues as well as patients with TMD issues. Do also understand that sleep bruxism is not the only thing that can give you headaches. Hypoxia can give you headaches, sleep fragmentation can give you headaches, and some of the sleep components can give you headaches. Even though I lean more towards a pain patient coming in that needs to be treated for, needs to be screened for sleep, I need you to think logically and go backwards. I could have a sleep patient in the chair today, and some of the data I showed you is showing that 51% of sleep patients have a TMD component. Well, if you're not screening for it, you don't think they have it. You start treating them for sleep, you might make them better accidentally, which is fine. I mean, you get them to breathe better, you control parafunction with the device you chose, and the TMD component that you didn't find got better. But what if they had a TMD component that doesn't get better and maybe gets worse? So we need to be mindful and take that into consideration as well. That when we have these patients, we got to look at both arms, pain and sleep, no matter what they're coming in for, right? It's very hard to separate one from the other. So with that, I'll take questions because I'm sure you got lots of questions here, and then we'll just go from there. So the question is, do you ever add a discluding element to a sleep appliance, make muscular pain worse, especially in patients where the vertical change isn't tolerable? Yes, Sarah. Unfortunately, I have had that as well. And what I found that happens in these patients typically is I will give them posterior stops. Contradictory to everything I just told you a second ago, there's a small subset patient population that if you give them posterior stops, especially when you put an anterior discluding element, for whatever reason, I tripod it. So two stops at the back, the anterior stop in the front, and it helps. Right, it helps. I may adjunct sometimes, Sarah, with some topical muscle relaxants. Maybe do a little bit of physical therapy or have them see a physical therapist, and with a combination, try and improve those symptoms. Another question is for a sleep patient who bruxes had anterior implants, would you recommend an anterior discluding element? So yeah, I mean, there's nothing wrong with it because at the end of the day, the forces will be dissipated. Implants are very firm, but if you feel a little bit gun shy, then use a different type of a device. It's called a mirror appliance that can be made by True Function, where it's not a discluding element to the front. The two pins are placed towards the canines more laterally. So you still get the same principle built in, but you just change the fact that it's not concentrated on the anterior. And the device is called a mirror, or the mirror design can be built into any of the sleep components that sleep appliance that you just seen a second ago. So it can be done, yes. Any more questions from anybody? I may throw one question out there. I get asked, so I'll just share this with you. The question that comes up every now and then is, if you have a patient that has a TMD problem, they come in and you put them, and you're going to get them tested, and it's going to take a few weeks to get them tested, which can happen depending where you are. I may use a sleep appliance like an EMA as an example, or a dorsal appliance from True Function, and I just build in the anterior programmer component, but I don't take a significant protrusive bite. I may just go edge to edge and just hold them there. So it's almost like a Farrar appliance or whatever type of appliance you want to call it. And then I wait for the sleep test to be confirmed. In other words, if the sleep test comes back positive for apnea, then I get a prescription file, and now I start cranking out the device, and then I'll start managing the airway component, right? So you can be very creative when it comes to the approach that one wants to use. Outside of adding a discluder, would you think about appliance design? So if I think about appliance design for just a second, all appliances, if I just think out loud, all do the same thing, right? They protrude the mandible forward. It might be the mechanics involved, but is it the mechanics that's causing the pain, or is it more what they may do at night with the device? In my early years, I would switch appliances out, and I found it was no better. I'd go from maybe a Herbst to a dorsal to something else and something else until I understood some of the mechanics involved. And I would just modify the approach of an appliance. We also have to accept the fact that we can't just bang our head on an oral appliance to make people better. Where I'm going with that is some patients, it may not work for them. You give them vertical, you take them protrusive, you add a tripartite design, you put an anti-discluding element, but for whatever reason, in this patient population, it just doesn't work. So we have to accept the fact that it's not an appliance problem, it's probably a patient problem at that point. And this is where the talk comes up that we may need to consider alternate forms of therapy. And there's no harm in having that conversation. I will at times have failures with oral appliances and have to have a convincing comment to get them to go back to PAP therapy, just so that we can try and minimize the flare up of symptoms that develop by wearing an oral appliance. So they can sometimes happen. Is a sleep appliance that limits range of motion better or one that allows more range of motion for parafunction, or do you find it's different? Yeah. Sarah, great question, my dear. And I would go with one that has more range. So I cover both entities. But I've seen the fact that if you lock someone in, especially like a dorsal appliance and there's significant bruxism, at times they'll break the fin off. But then I have patients with significantly worn down teeth and they wear a dorsal appliance and then don't do any destruction or damage to it, right? So I'm sure there's other variables that may explain why this is so. So I just go with the premises of taking a device that just gives me a little bit more range. So my choices might be like an EMA, a Herbst appliance for sure. A Dream Tap could be an option here as well. Um, so yeah, so I have a little bit of latitude if I need the latitude. Do you ever convert your Farrar appliance to flat plane splints? How do you make the clinical? Yeah, I do. I will make that decision once I've seen that the patient's stable for at least 3 months. My fear with keeping them something that keeps the jaw forward is a possible change in bite over time. So if their symptoms are stable, I may ask them to not wear it a few nights and see does anything happen. If they say nothing happens, then this is the time where I may convert it to a flat plane splint. All right. But I like to keep a little bit of protrusive component if I suspect they have a sleep breathing issue and they're not willing to go get a test done, then I'm just a little bit hesitant to cut the ramp off because I don't want to make something worse when I can maybe keep them where they are or maybe make them a little bit better without even knowing it. So I will only make those conversions if I don't think there's a high risk for having or suspecting apnea, and two, if they can go without the device for a period of time and nothing kind of returns. Would you recommend, what would you recommend during the day for the patient until sleep study is complete? Um, so it depends on the diagnosis once again. A day appliance would, to me, would mean either they close lock, they have a clicking joint that's a major concern with them, there's pain associated with it. Maybe they have some arthritic change in the joint, which will be only the reasons why I would consider a day. Um, if I had to use something temporarily, I may use aqualizers. All right. There's an appliance called an EMA Now, which is a temporary sleep appliance that you can use. So it's a two tray upper and lower. I may just use one tray, put it in the bottom, run some cold cure acrylic on top, and just give them something to give them some form of height. But to be quite honest with you, I don't use a day appliance if I'm in this holding pattern. Only because if they've waited 3 months, 4 months, what's another 10, 14, 20 days? I may give them medications to control their pain until I can get until I can get the sleep study results. I had a patient who landed up having anterior open bite after using CPAP for 5 years. Which muscle groups or cranial issues can lead to this condition? I don't know how to answer that question. I don't know how to answer that question. I apologize, Dr. Kata. When you look at a CPAP and the way it works, the forces in the front depend on the type of mass they have, right? But once again, it'll be on the premaxilla, on the mandible. I can only say that possibly could it be that they have a large tongue, blowing the air through a nasal cannula, they were probably tongue thrusting, and as a result of the tongue thrusting led to an open bite is my only explanation. But without understanding the patient and looking at some of the craniofacial morphology of what they look like, I'm suspecting this person has to have a large tongue and probably a more of an anterior thrust habit. That would be my only consensus. Because if you look at how a CPAP works, it blows the air, right? So if it's going through the nose, it's going to go to the posterior part of the junior glossus. If the pressure is high, the tongue may move more anteriorly and therefore create a thrusting-like effect that could potentially lead to an anterior open bite, is my thinking out loud here. Is it possible to correct it without surgery? I mean, if it's due to tongue thrusting, myofunctional therapy could be the first line that one could take into consideration with tongue posturing. But we need to understand the mechanism of why they have the thrust. There's no point in myofunctional therapy if the underlying issue is maybe the PAP. This is a tough one because if the CPAP is working and it's keeping them therapeutic, I would not say move them to an oral appliance because you have to build the oral appliance on an anterior open bite. So it gets kind of tricky here, right? And if you do myofunctional therapy, it runs the risk once again of relapsing because 6 to 8 hours they're gonna wear the machine again.
Do you see Dr. Kata said that she does have a large tongue?
She does have a large tongue.
Mhm.
So I mean, I would lean more towards educating the patient. There's probably a side effect that's associated with it. There's really not much one could do if they're okay with it. I mean, live with it. Not that with an entry open bite, you can't have a quality of life. You just have to cut up your food and so forth. But you got to outweigh the benefit of changing their form of therapy just to minimize that. I don't know if it's fair to the patient, if it's working for them. Oral appliances that we use have side effects too, as you all know, posterior open bites, but we don't stop giving them oral appliances. We just educate them and hopefully they try and mitigate that risk from actually occurring. Do you have any opinions on material selection, soft liner, all acrylic, nylon for someone with pre-existing TMD symptoms? When it's a pre-existing TMD symptoms, material choices doesn't really matter at that point, right? I would go towards a thinner material. Nylon could be one. All acrylic, I do prefer. I do not like soft gauze. It's just a chew toy for these patients, making the myogenic pain more worse. Soft liners I will use if there are a lot of like veneers, a lot of crowns, things like that. I will have a soft liner added to an acrylic appliance, but no specific appliance material choice if they have a TMB pre-existing issue. Is occipital neuralgia can increase with night bruxism, and also what appliance do you recommend to reduce the bruxism in this case? So the occipital neuralgia, the key is to address the neuralgia. When you have occipital neuralgia and you're sleeping in your bed, what will happen is that every time you hit that hot spot, your reaction to pain is you will clench, right? You'll grimace. As a response, you'll increase more myogenic pain. A device that I would use would be anything that there's no posterior contact to minimize the force that could be created. So anything like an antideprogrammer, a mirror appliance, anything like along that spectrum is where I would go. But more importantly, I would try and get them to get the occipital neuralgia under control. This could be taking medication like Tegretol. It could be getting occipital nerve blocks along with some steroids. And worst case scenario, there's a thing called radiofrequency ablation where they can burn the nerve to control the occipital neuralgia symptoms as one component for it. Do I ever do short-term treatment of muscular pain prior to initiating the sleep appliance so the muscles are more relaxed prior to delivery and long-term? Yes, definitely would do that. I would use a quick splint. Thank you. I would use a quick splint. I may send them to PT. I'll give them home care instructions. I may use some muscle relaxants short-term. I may do trigger point injections, whatever it takes to break that acute state. Because if you think about it, Sarah, and I think you would agree with me, it's going to take 2 weeks, 2.5 weeks, 3 weeks to get the appliance. Why not me, therefore, make the situation better? So when the device comes in, it's a quick smooth transition, and I'm not having to deal with some of the acute hiccups that may happen. So yeah, if they're really in a lot of pain, I will prioritize pain, but I'll still get the sleep thing addressed simultaneously if I suspect that's a component associated with it. But yeah, quick splints definitely a go-to. A lot of great questions. A lot of people still on, which is good as well. Well, we have two announcements that we want to make.
Excellent.
Sure.
Yeah, and if you still have questions, continue to put them in the box. We can address those too once we hit these last couple slides. Regarding the quick splints, the EMA nows, all of those temporary devices, you can purchase those right from truefunction.com. So if you are wanting to stock up and have those handy in your practice, we do offer those. When it comes to our next webinar, that is all on appliance delivery. So device delivery might actually be really helpful based on some of these questions that we are addressing this evening. So it's going to be with Frank, our founder and president here of True Function, on troubleshooting device delivery. That is actually going to be on a Tuesday this time on June 24th. So you can actually register on our education page on our website or that right QR code on the screen there. If you're not a True Function client and you'd love to work with us, or even just kind of troubleshoot with us and have some additional questions, always feel free to fill out our new account form. We're happy to kind of help troubleshoot you and get through that process of implementation and getting those appliances ordered. So you can fill out a new account form on the QR code on the left. And then last but not least, our device special for the month of May is our acetyl device. So that is a really nice thin material, like Mayoor was saying that he likes, specifically a milled thermoplastic type material. So it's 20% off through next Friday if you order any device in that acetyl material using code acetyl20. on your QR or on your, excuse me, your notes of your RX or your promo code section of DDX. So I do see a couple more questions come in here, so we'll switch back to Dr. Patel, let him answer those before we get conclude here.
So this acetyl appliance is amazing. I will share that. I've been using it a lot more lately. It's got a little bit of good flexibility to it. So people that Brux, I like this because it's got a little bit of durability from the standpoint that it's not as rigid like an acrylic device. But more importantly, it's a very thin device, right? So once again, the biggest culprit in all these patients is the tongue. So why put a thick appliance in there if you're trying to preserve tongue space? Acetyl is a good choice, all right? And some of the milled appliances are definitely a good choice. For preserving tongue space. The question is for a clencher bruxer with occasional morning jaw pain, do you prefer a very rigid appliance or a soft material? The key is rigid. I don't want anything soft. A soft device, unfortunately, like I said a second ago, it's almost like a chew toy. First 3 to 5 to 10 days, they feel better. After that, the pain actually gets worse because they keep on springing on that device over a course of time, which then will lead to more myogenic type symptoms. So I prefer a solid stop, something very rigid. The softness could be the line on the inside for comfort, but the shell itself needs to be hard. Okay, well, I think we're good there, right?
Yeah, that's it, I think. Thank you all for joining us this evening. Thank you, Dr. Patel, as always. We're so grateful to have you join us. And hopefully we'll see you again before the year's over. Wink, wink, I'm going to be reaching out to you.
Yeah.
I can have him send me a copy of the slides, so I have them and I can send them out with the recording. We will be sending out the recording probably early next week, so you'll have a copy of that if you want to go back and reference anything that he discussed this evening. And other than that, thank you again for joining us, everyone. We'll hopefully see you next month on Tuesday, June 24th for our next webinar. And if you need anything in the meantime, don't hesitate to reach out to us.
Thank you, dear.
Thank you.